Hi, this is Mark Kosko. I'd like to share a case of a laser-assisted cataract removal with a Panoptix intraocular lens. We're infusing some lidocaine and some non-preserved epinephrine, including right underneath the edge of the iris. Sometimes the laser can make the pupil want to come down, and so we're trying to prophylax against that. Here's some viscoat that we're using to fill the anterior chamber. And you'll notice that I actually really strongly prefer not to use the laser to make the incisions. A diamond or even a good keratome is definitely superior to the laser incisions in my opinion. Laser incisions have to be made slightly anterior, and thus they can induce more astigmatism. They cause more scarring postoperatively as they heal, and they have higher endothelial cell loss. To me, the only good reason to use the laser would either be if you, I guess, just don't really know how to make a very good incision, or if you want to be able to market the term, quote, blade-free, which I just don't think that's good, because it's not what's best for the patient. So I really do prefer a diamond or even a keratome. But anyways, I digress. We've gone in with the pink sleeve phaco tip on our Centurion phaco. We're using the Rosen 60-degree vertical chopper to separate the lens along the places where the lens X has broken the lens apart. I've actually not edited the phaco portion here at all. I really do want folks to see how I sort of slowly go around and disassemble the lens. I really don't want any stress on the zonules. I want to use as little phaco as possible. I want to try to do all my work either at the iris plane or really honestly even at the anterior capsule plane. So we're just going to separate the lens into all these little pieces that the laser is sort of pre-fragmented. I really do think this is done best manually. It just kind of breaks my heart to see folks use the sculpt function when the laser is already kind of done all this for you if you would just chop it. The laser does make this nice. I do always tell patients, the laser, in my opinion, is a little bit better than traditional phaco, but it's only slightly better, and I think it's fair for patients to know that. This is not something, at least the laser portion of this, is not something where you would ever want to miss a trip to Disney World with your grandkids because you paid for the laser. But if it doesn't put a financial burden on you, I do think the laser is slightly better. So take that for what it's worth, and I'm extremely honest with every patient about that. The laser is better, but it's only slightly better. So again, we're just being real careful to take our lens out with just short bursts of torsional phaco, mostly just using high vacuum here. Being careful to do it away from the cornea, but also protect the capsule. And we still actually have viscoat against the endothelium because we were so deep, but there was viscoat left over in our syringe, so before we came out we just put the last little bit in. Sometimes on the laser cases you can have a lot of BSS going through the eye to get the cortex out, and so we do want to keep protecting the endothelium. We're going to go subincisional first here. You really do want to try to grab the anterior aspect of the cortex. You'll get way fewer strings of cortex left over in the eye that way. You really don't want to leave those. A lot of people do, but you'll get a way quieter eye if you can just real diligently, meticulously get every last little strand of cortex out. I really do think if you do, you can almost put these patients just on an NSAID, and they do fine. I haven't changed my protocol there, but they really have such quiet eyes. If you are just tedious and OCD, to get it all out, grabbing the anterior aspect and stripping towards the center. We're going to meticulously polish the posterior capsule with the polymer tip on the IA here. We're going to fill that with Provisc here before we come out. Really do want to keep the eye deep the entire case. This patient was referred from his optometrist for increasing glare with stuff like night driving and anatomical narrow angle. He was hyperopic, and he had been happy in a multifocal contact lens from his optometrist for a number of years, and he really did want to stay with a similar lens implant on the inside of his eye, and that's why we chose a Panoptix. Here we're meticulously polishing the underside of the anterior lens capsule with a Singer polishing system. We've got a Singer sweep on one end and a curette on the other. Here we're using a wound assist technique to inject our Panoptix IOL. You can kind of see all that debris in there. Those are lens epithelial cells, and when you start polishing more and more and you see that stuff in the eye, you'll just sort of say, gosh, I sure don't think I'd want to leave that stuff in my eye. But what we're going to do now is we're going to get all of the viscoelastic out of the eye, all of the lens epithelial cells that are swirling around in the viscoelastic. We're going to go underneath the lens to get all of that material out from behind the lens. We'll just meticulously get every last bit of it out. We really do want these eyes to come back to their referring optometrist with just even just less than trace cell. You just want it to be pristine. Here we're pulsing BSS both into the sulcus and to the capsular bag to irrigate out what I just call lens dust debris, as well as viscoelastic, and we're just getting it all out here. Here I've got a freeze frame showing that I'm lining up my Purkinje images to get this lens well centered, and we're going to hydrate our incisions. This patient did awesome and was so happy. Can't wait to come back and have his second eye done. And we gave some cefuroxime there at the end. It's really important to use intracameral antibiotics. That's it. He did great. Thanks so much for watching.